Each week, I hold 1 or 2 forums in the district on topics vital to your life. Here's another show that we taped.
How are we defining diabetes? And this is whether it's type 1 or type 2 diabetes. And diabetes is very, very prevalent. So if we're doing a fasting blood sugar, we want that blood sugar fasting to be less than 100. If it is between 100 and less than 126, you have what's called prediabetes. And if your fasting blood sugar is greater than 126, then you have diabetes. If you're doing a glucose tolerance test at the 2-hour mark of a glucose load, after the 2-hour mark, it should be the blood sugar less than 140. If it's 140 to less than 200, that's prediabetes or at risk for diabetes. And greater than 200 is considered a diagnosis of diabetes. Okay. For the last few years, we've also been using a diagnosis with an A1C. So that blood test A1C is going to be what the average blood sugars have been over the last 2 to 3 months. And so A1C greater than or equal to 6.5%, also criteria for diagnosis of diabetes. Type 1 diabetes. So if we think that there are more than 20 million people in the United States who have diabetes, only 5 to 10% of those individuals have type 1 diabetes. So type 1 diabetes, there's a genetic component to it, and then they feel that it's autoimmune. So autoimmune means that the cells that are producing insulin, for some reason, start attacking the cells that produce insulin till there are no longer cells that produce insulin. Okay. They think that what triggers off the response, so people can have autoantibodies to type 1 diabetes before they actually develop type 1 diabetes. They feel there's something viral or something environmental that triggers off this autoimmune response that then makes the cells attack those cells that are producing insulin. And then we see high blood sugars after about 80 to 90% of the beta cell destruction. So the beta cells are the cells that are producing insulin. So up 80 to 90% have already been destroyed by the time we see an individual with high blood sugars. Let's switch over to type 2 diabetes. So type 2 diabetes, they're at a different genetic predisposition, and initially they are producing insulin. However, the insulin that they're producing is not working well enough because that individual has what's called insulin resistance. And a lot of times that insulin resistance is related to obesity. So what do we see when we do blood work on this individual? We'll take blood, we'll do an insulin level. We see high insulin level, but we also see high blood sugar. In type 1 diabetes, we'll do blood initially at diagnosis. We'll see high blood sugar, but we see low insulin levels. So they're not producing the insulin. Any questions? What happens though with research, they found that the individuals who have type 2 diabetes, the cells that are producing insulin, those are the beta cells, they poop out along the way. Poop out, you know what that means? They get tired. They're tired. And they're not gonna produce insulin anymore. And so what does that mean? That means the individual who has a diagnosis of type 2 diabetes, in order to control blood sugars, will need to be started on insulin. Now, is that a bad thing?
I think so.
Is that a bad thing? I told you that I have type 1 diabetes. And I told you that with type 1 diabetes, those people, those individuals are not producing insulin, which means then we need to be on insulin. So I've been on insulin for almost 40 years of my life. If I didn't tell you that I was living with type 1 diabetes and have an insulin pump somewhere hidden in my body, would you have known that? No. No.
What if they don't give insulin, give a pill?
So the insulin does not come in a pill form that's effective. There are a lot of medications to treat type 2 diabetes. They work on other parts of our body, such as the liver, like metformin or glucophage. It makes it so that the liver doesn't dump so much glucose into the bloodstream. Okay? But when you have an individual with type 2 diabetes on 2 or 3 medications by mouth, and they still have a high blood sugar or a high A1C, they need to go on insulin. And insulin's a sure thing. It's going to work. It's the hormone that needs to be replaced in the body then. This is called acanthosis nigricans. It's a very, very prominent skin marker of insulin resistance. So sometimes we get individuals or kids saying to the parent, I think this is dirt. I'm dirty. I keep scrubbing this and it's not coming off. But it's not dirt. It's acanthosis nigricans. It's a cutaneous marker of insulin resistance. Childhood obesity. I'm sure you've seen some of these kids running around on the street. We have individuals in our practice being treated for type 2 diabetes. We have children who are 300 plus pounds. Okay, so they receive a lot of education. And who is at risk for developing type 2 diabetes? Children, especially between the ages of 10 and 19, with a family history of type 2 diabetes. A history, if the mom has a history of gestational diabetes, so gestational diabetes is diabetes when the woman is pregnant, but then goes away when she delivers the baby. However, those individuals may be at risk for developing type 2 diabetes later on in life. Diabesity is obesity with diabetes. Okay? And they go by what's called the body mass index, and there were some papers over there to say know your risk about your BMI to see if you may be at risk for developing type 1 diabetes based on your weight. Because what did we say? We said that there's insulin resistance with type 2 diabetes. However, when an individual can lose weight, at least 5 to 10% of their body weight, we see that their insulin that they're making is working the right way and harder for them. So it's important to have a healthy weight and to exercise. This is just a way to calculate BMI for the individuals here in this audience today. There are charts. So there are charts that we can use that plugs in the height and the weight, and it comes out with the BMI, body mass index, to show if you're at risk, moderate risk, or high risk for developing type 2 diabetes or having obesity. When it comes to individualizing this in the pediatric population, our nutritionists are looking very closely for healthy growth and development. So they're going to look more closely at what the body mass index is. And is that child underweight, at a good weight? Are they slightly overweight? Or are they morbidly obese and that this is a very serious condition? Because what does obesity lead to? It can lead to insulin resistance, type 2 diabetes, obstructive sleep apnea. How do we know if somebody has sleep apnea? They might be breathing, so they might be snoring. They might be snoring, and then all of a sudden, if you're sleeping next to somebody, they might be snoring, and then all of a sudden you don't hear any noise. That's because they stop breathing for a little bit. Okay, then they start snoring again. Usually individuals like that, they're asked, of course, to lose some weight, and they may need to go see a sleep specialist and get a sleep apnea machine. Because sleep apnea has its own set of problems that goes with it if it's not treated. It could lead to high blood pressure, more weight gain. It could lead to less sleep, less of the good sleep. And certainly, oh, come on in. And certainly, we don't want that happening. Okay, we don't want people out on the road falling asleep because they have sleep apnea, right? Poor self-esteem, a lower quality of life, And 80% of obese children carry this into adulthood. So in our pediatric population, we want to try to educate the families and help them with a rigorous weight loss program that's also going to include activity. One of the biggest issues is portion control, and our portion sizes are a lot larger than what they were years ago. What does that mean? An extra 100 calories a day can lead up to a 10-pound weight gain in that year. Okay? And so that's significant, right? That's very significant, especially if you're trying to lose weight and yet you're gaining the weight. So physical activity, the American Academy of Pediatrics says that 45 to 60 minutes of a moderate to intense exercise daily. Now this is a hard sell when people love, what do the kids love these days? They use their fingers and it's not washing dishes. Xbox. It's very hard to get them away from the TV. And not all exercise needs to be a rigorous program. You don't need to go to the gym. You can put music on in the house and dance around the house. Yes, you could do housework and you could ask the kids to do some vacuuming. It could be spread out throughout the day. You could do it in 10-minute intervals, right? But you need to get some exercise in. And organized sports, if you want to do it as a family, which works the best when it comes to type 2, is treating it as a family. If you have a dog, go walking the dog. Go for walks. Do a family activity that's not eating in front of the TV. So as a review, type 1 diabetes, the pancreas is not making enough insulin, and that individual right away, after diagnosis of type 1 diabetes, needs to be placed on insulin. In type 2 diabetes, the pancreas is initially making insulin, however, it's not being utilized properly because we still see high blood sugars. And so yes, there are multiple amounts of medications on the market these days to treat type 2 diabetes. But if an individual is taking 2 to 3, 4 medications and it's not controlling those blood sugars, that individual needs to go on insulin. Okay? And all individuals with diabetes, whether it's type 1 or type 2, should really be followed by an endocrinologist, a specialist who's going to know what's the newest, the latest and greatest out there to manage blood sugars. Okay? Type 1 and type 2 can occur in childhood or adulthood. The incidence of type 1 diabetes is increasing at a rate of 2 to 5% per year. We also see an increase in type 2 diabetes. The risk of diabetes is about 5% with a first-degree relative versus 0.4% if there was nobody in the family who had type 1 diabetes. What is the significance of that? Well, there is a genetic component to type 1 diabetes. And the exact environmental factors responsible are still not known. Signs and symptoms of diabetes. Well, we say peeing and drinking a lot, frequent urination and drinking a lot. The individual will say, like, I'm just so thirsty, I could just drink like the kitchen sink. Okay? Feeling tired, having a weight loss, blurry vision, feeling hungry, because what's happening is that in order for the body to process sugar, you need insulin. Okay? And when there's not enough insulin, the sugar is being peed out into the urine, and that person is feeling hungry and dehydrated because that individual's not getting the nourishment. So diabetes management plan is going to include education, intensive education, education from a diabetes nurse educator, education from a nutritionist, a social worker. Do we have social resources? Do you have the insurance that you can cover for meters and strips and insulin? And the endocrinologist to set up that plan. Blood glucose monitoring, checking blood sugars. How often should you check blood sugars? Insulin administration or other medications, healthy eating and carbohydrate counting, and exercise. Why is it important to control blood sugars? Well, the Diabetes Complications and Control Trial that was funded by the National Institute of Health ended a year earlier. It's a 10-year landmark study that ended. They stopped it a year early because what they found was that the individuals who had better blood sugar control had less incidence of eye disease, which is retinopathy, nephropathy, which is kidney disease, and neuropathy, which is nerve damage. So if you see on the curve, as the blood sugars are going higher, on the left-hand side is the A1C. That's the 2 to 3 month check, the blood check that we see how the average blood sugars have been. Okay. So the higher the blood sugars, the more at risk you are to developing complications. These diabetes-related complications. Any questions? Just to go, let's see if I can go back a minute. Just for you to understand a little bit, a 7% A1C means your average blood sugars are about 154. A 6% means your average blood sugars are about 120. Okay, so just so that you have an idea of where these numbers are coming from. And then as we go higher for each 1%, you're adding about 30 milligrams per deciliter. Okay, so an 8 would be, 8% A1C is 180, a 9% is 210. Okay.
I have a question.
Yes.
Oh, you just fixed it.
Oh, I'm sorry, what? No worries, no worries. There we go.
Neuropathy?
Neuropathy is nerve damage.
That has to do
So
with
that
age?
has to do with your feet, not being able to feel the sensations in your feet. So I actually have a colleague who said to me that he had a little cut, a colleague now, so we're talking about adult with type 1 diabetes. He had a little cut on the bottom of his foot. It wasn't healing, but he wasn't too nervous about it until he saw yellow pus on his white socks. Okay, now he's got a nice big infection on his foot. He actually had part of his toe amputated. And once you have something amputated, you're at a greater risk for having the next toe or your foot amputated. So foot care is very, very important for the individual living with diabetes. To examine your feet. If you can't examine them, ask somebody to examine. Wear white socks, like that. So that's nerve damage. Nerve damage could also include erectile dysfunction for men. Okay, but this is a pediatric talk, so I'm gonna stick with the, won't go into erectile dysfunction right now. Any other questions about this?
The fact is that I went to the doctor about a week and a half ago, and I was wondering why I was gaining weight, even though I walked like 3 miles a day in the morning.
Yes.
And I would, watch what I eat. So then I had blood work done, and when I went, he said that my sugar was up, and that was causing me to have getting the weight gain. And my sugar was like 108, and it's usually in the 80s, he says. So.
And this was a fasting blood sugar?
Yeah.
And so if we went back to our screenshot of the first slides, you are more than 100 fasting, but less than 126, so you're at risk for diabetes.
Yeah.
So
that really scared me. So I said, okay, whatever I have to do not to get it, I'm gonna do it.
Good for you. Good for you.
I have a question.
Yes.
My mom, who is 93 years old, she's diabetic, and she had several strokes. and she's on liquid diet, and her sugar goes up to like 200, 250, you know, some various numbers. What do you think that causes her not having solid food and having liquid diet, and her sugar goes crazy at times?
So I mean, this is an individual question.
Yeah.
Liquid diet could also be high in sugar content, I'm not so sure, right? And I'm not sure what her medications are to manage these blood sugars. So I suggest to you to address that question, it's a very valid question, with her physicians.
Well, it has been addressed with her physician, and he said, well, all she has to do is just take the medication. The medication he gave her, I don't really know the name of the medication, because I'm not the one who was giving her medication. But each time when I'm there and realize that the sugar goes up, and I'm asking why, and what happened to the medication, it's more like it's the medication that does it, because it doesn't ease up. It fluctuates, you know, in the morning it is this number, like high, then in the evening it may be low, it just, you know.
I would still address your concerns with her physician, because they're gonna know the whole history of all the medications she's taking, any interactions with those medications, and side effects.
And he's the one that called her the medication.
I would still address it. I wouldn't let it go. I would just, say, when somebody says, I have a concern, this is what we're taught in the hospital, I am concerned. I am very concerned. That means you want somebody to listen to your concerns, and I would just express it that way and see. Maybe that medication isn't working, and say, hey doc, maybe we can switch to another medication, I'm concerned. Okay?
I don't really know the medication, but certain medication she's taking that he has put her on, it doesn't make any difference. It just goes bad. Well, it doesn't stay the same way all the time. It's like 95, then it may be 100 and something. So it's like, you know, just leave it like that.
In an individual, I'm not sure what her medical history is, when we say what the target goal should be for blood sugars, you know, when it's a young child or a baby, like we have babies less than 1 year old with type 1 diabetes, we're not gonna be so worried about tightly controlled blood sugars on a baby, because the risk is for low blood sugar.
Right.
And maybe he's thinking the same thing for your mom. I would just ask him then maybe to explain it to you a little bit better so that you can understand and feel a little bit more comfortable with that decision. Okay? Monitoring blood sugars, and so why do we check blood sugars? To know where the number's at, and for safety, especially if we're taking medications, and to see if those medications are effective. Okay? To know the results within a few seconds, to adjust doses of medications, understand the effects of the foods that we eat, right? Stress makes my blood sugar go high. Exercise can make somebody's blood sugar go high or go low, depending on that individual. And to provide a sense of control, so this individual knows where they're at, right? Kind of like a roadmap. I had to do GPS to get here from my office, because I didn't know where I was going, so it's like blood sugar checks. We need to know where we're going with our blood sugar management. So a lot of times people are asked to check before meals and at bedtime. An intensive management program, especially for individuals who have type 1 diabetes on insulin, and the type 2 individuals who are on insulin with an insulin to carbohydrate ratio where their insulin is actually matching the amount of carbs they're consuming. They ought to be checking blood sugars definitely before meals, before they're eating snacks, and at bedtime. This is a pediatric lecture. So these are what are the goals based on Diabetes Care 2016 for A1C control as well as blood sugar control before meals and at bedtime. Can you see?
A little bit. Okay, thank you.
You want to move over? You can move over somewhere. There's plenty of chairs. It might be a little bit easier. Okay? In adults, when they turn age 18, that A1C becomes less than 7%. Okay, so we want to have tighter control as an individual then goes into the adult world. I was talking about the correlation of what an A1C value is with your average blood sugars. Okay, so that's important to know. And the goal for pediatrics is less than 7.5%, and the goal for adults is less than 7% based on American Diabetes Association guidelines. There are things what's called continuous glucose monitoring systems. For short, it's CGMS, where you have a wire underneath your skin. Okay, in order to get the wire underneath the skin, you need a needle, a guide needle to stick it in there. And then what sits on top of that is a transmitter to pick up the interstitial, which means the tissue glucose readings. And then you need a receiver of that information. So right now in the United States, CGMS, continuous blood glucose systems, are not FDA approved to replace blood glucose monitoring. They are talking, it's on the table, they're talking about it. With one of the systems, it's Dexcom and the FDA. And over in Europe, Abbott has a product out there that they're looking to get into the United States and to actually replace blood glucose checks. So it'll be very interesting to see where does technology take us. So this is the Dexcom system. That's the receiver. This is the transmitter. He's here. This is the sensor, the wire that's gonna go underneath our skin. This could be the receiver, or you can have your iPhone as a receiver. If you have the iPhone as a receiver, then you can have up to 4 to 5 followers. So as a child is in school, mom or dad at work on their iPhones are able to see what the real-time glucoses are. That's good, right? I'll never forget, a few months ago, I was at a JDRF event, Juvenile Diabetes Research Foundation event, and one of my moms, which means one of the parents of a child that I take care of in my practice, was there, and she's holding up the phone. This is the best thing ever. This is the best thing ever. So she's holding up her iPhone, and she shows it to me, and she goes, look at his sugars. He is at his first sleepover, and I feel comfortable sending him there. You know, that speaks volumes about the trust that the parent has to give to the other parents where her child is going to be sleeping over, a sense of security to know what those sugars are. And one of the biggest fears that parents have is a child having low blood sugar in the middle of the night. I have parents waking up 2 to 3 times a night checking the kids' blood sugars. They're not getting sleep, they're sleep deprived. When we upload those systems, we're able to look at trends and patterns. We want to identify some patterns and make adjustments in medications, mostly insulin adjustments. Okay? I've been talking about insulin a lot, right? Well, what is it anyway? It's a hormone. It's made by the pancreas, and it's used to allow the sugar to enter the cells so that the cells then have energy. Insulin must be injected in the pediatric population. It's an injection. There is an inhaled insulin out on the market. It's approved for age 18 and up. It's called Afrezza. But since this is a pediatric talk, I'm going to stick with subcutaneous insulin. We don't want it going into the muscle because it would be absorbed too quickly. We have different kind of insulin on the market. We have fast-acting insulin, which is called our bolus insulin, our insulin that we're going to use to take for our meals or snacks. And then we have a long-acting insulin, our basal insulin. Okay. So this is what physiologic insulin secretion profile looks like. If you are an individual whose pancreas is working properly, your pancreas, and you're sitting in this room today, your pancreas is producing insulin as you're sitting here listening to me. If we decide after class to go eat something, let's pretend we're going to eat something, your pancreas will then produce insulin to address the carbohydrates in that meal or snack. An individual with diabetes needs to take some basal insulin, which is that flat line. As an injection, it would be either Lantus or Levemir. And then, for those meals or snacks, needs to take that rapid-acting insulin as an injection, or they could do this using an insulin pump. Okay? If we're doing injections, think about this. A pediatric child with type 1 diabetes on multiple injections a day eats 3 meals, 1 snack. That means they're having a rapid-acting insulin at breakfast, lunch, dinner, snack, and they're gonna have that bedtime basal insulin of the Lantus 11-year. 5 insulin injections, right there. Plus, at least 5 blood sugar checks. That's a lot of work, right? We also talk to the families about the importance of not only taking the insulin, but taking it properly. Because if somebody does insulin injection in the same spot all the time, they may get scar tissue. Because there's a buildup there, so they may get scar tissue. And then they're not going to get a good insulin absorption. And it's especially important in the pediatric population because when they did measurements of the skin circumference, a lot of these little kids, especially in their arms, only have a small amount of skin. So we talk about rotating the sites. And where can we do insulin injections? The back of the arms, the belly, staying 2 inches away from the belly button, going out to the sides, love handles. You slice your booty in quarters, it's the outer portion here. Here, when we have babies in diapers, this is a good place to put insulin injections. The thighs, we could do the top and the sides of the thighs. And we try to rotate within one area for about a week first, and then move to the other area. So what I tell families is we're not gonna do the Macarena. You know the Macarena?
Yeah.
You know, I did it here this morning here, but then they don't remember where they're really going. And those are the ones who end up going same spot, because they, oh yeah, I went right there, I'm gonna go right there again. Okay, so rotation within the area. This is what it looks like. There's a little pouching out of the area. This is scar tissue. We call this hypertrophy. Okay, so we wanna avoid that. You see that, yes? Our basal insulin is the Lantus 11-year. Kids take it if they're on multiple injections once a day. It usually lasts about the 24 hours. And they usually give it at bedtime. Our bolus insulins are Novolog, Humalog, or Pedra. That's given for their meals and snacks. We usually put them on pens, and this fast-acting insulin starts working within 5 to 10 minutes, working its hardest in an hour, and lasting anywhere from 3 to 5 hours. We use it to address the carbohydrate content in the food, as well as an opportunity to get high blood sugars back into target range. So when we're teaching this, it's actually a math class, and I'll show you why. So here we go. They're gonna give, the individual is gonna get an insulin to carb ratio. It's gonna be based on their weight initially. Okay, so it's an amount of insulin, 1 unit, for X amount of carbohydrates. Okay? So let's say that this individual was told that she has an insulin to carb ratio, 1 unit for every 25 grams of carbs. And if she was gonna eat 75 grams of carbs, you do the math, that means 3 units. Okay? Keep that saved in your mind somewhere. How do we know that that is the right thing? Well, hopefully they're doing good carb counting. They're gonna check their blood sugar in 2 to 3 hours. We only wanna see a 30 to 40 milligram per deciliter rise in that blood sugar reading, okay? If that didn't happen, then maybe you miscalculated your carbs, or we don't have the right insulin to carb ratio. This morning when I was taking care of one of my patients, the young lady's blood sugars were going high. I saw this pattern, high after every meal. And her insulin to carbohydrate ratio was 1 for every 25 grams of carbs. I changed it to 1 to every 22. It looks like I'm giving less insulin, but I'm actually giving more insulin. Okay? Just like if somebody had an insulin to carb ratio of 1 unit for every 10 grams of carbs, and let's say they were eating 90 grams of carbs, they would need 9 units. But if I changed the insulin to carb ratio of 1 unit for every 9 grams of carbs, and they were eating 90 carbs, they would need how many? 10, right? So that's more insulin. Correcting high blood sugar. It's the amount of insulin needed to get the blood sugar back into a target number. So the physician office will give you what the target blood sugar should be and give you what's called a correction factor. 1 unit to lower you by X milligrams per deciliter. Approximately 1/3 of these insulins, these analogs, the Humalog, the Novolog, or the Apidra, they basically all work in the same. They're by different manufacturers, and a lot of times this is insurance driven. So let's do a correction example. Let's say the blood sugar is 200 and the target blood sugar is 150. If you do 200 minus 150, we're actually 50 points above our target blood sugar. If we said that your insulin to your correction factor, 1 unit, lowers you by 50 points of blood sugar, and we do the math, 50 divided by 50 gives us 1 unit, right? And if we're having those 75 grams of carbs, when our insulin to carb ratio is 1 unit for every 25 grams of carbs, we needed 3 units for that, plus the 1 unit to correct our blood sugar, then we need a total of how many units? 4, exactly. I told you this math class. One of the hardest things teaching families, a diagnosis of diabetes in the pediatric population comes as a shock usually. And we teach about insulin, oh, they're going to need all these injections. Okay, they see that the needle is so tiny, it's going to be okay, it really doesn't hurt. But when we do all the math though, and practicing with all these examples, then they get overwhelmed because they're not used to doing all this math. So we use calculators, now our smartphones have calculators. So that's a good thing. Okay, what is an insulin pump? Has anybody seen an insulin pump? No. So it's a small battery-operated, pager-sized, computerized insulin delivery system. You need a reservoir or syringe for the insulin storage. Then you need some tubing. The tubing comes in different lengths, anywhere from 23 inches to 43 inches. And an infusion set, because we need something in the body to actually get the insulin in there, right? Okay. This is one of the insulin pumps on the market. It's an Animus one-touch ping. On the left-hand side, that's an ultra smart meter where you can check a blood sugar using one-touch ultra test strips, and then you can also bolus to your pump while your pump is tucked away under your clothes safely. Okay. They also have another meter called a Vibe that's integrated with a glucose sensor. This is a Medtronic pump. You see the tubing. This is the reservoir here. So you put insulin in this cartridge here to the tubing to an infusion set. This infusion set goes in by a needle. The needle comes out, and what stays underneath the skin is a little catheter. Does this hurt going in? Usually not. It's just like a little pinch. Has anybody here had their blood sugar checked? Do you know what it's like? It's just a little pinch. This is just like a little pinch. This up here is actually a glucose sensor from a different company. This is the Medtronic one. They just updated their pump last week on Thursday, and I was just at the meeting. I came home last night from San Diego for the American Association of Diabetes Educators and got to see their new pump with a nice new integration. It is now waterproof. The other pump was also waterproof. Okay? This is a pump that has no tubing. This thing is called the PDM, Personal Diabetes Manager. Uses freestyle test strips, so it's a testing machine. And this is the pod. You put the insulin in there and put it on, it'll automatically then stick the needle in the skin, it gets retracted, and the little catheter then stays underneath. There's no tubing. They change the pod every 2 to 3 days. You check a blood sugar, and then you bolus remotely to get the insulin. So what it's gonna ask for is, okay, you're gonna eat now, how many grams of carbs are you gonna eat? Right, whatever it is. And the doses are programmed in there. So instead of multiple injections, an individual could wear an insulin pump. The way that they're getting their basal insulin is by staying attached to their pump or wearing their pod all the time. Okay, it's gonna have rapid-acting insulin inside there, the Humalog, the Novolog, or the Apidra. Okay, so 24/7, the clock starts at midnight. You have different amounts of insulin throughout the 24-hour clock. That's gonna be your basal delivery. And every time this individual is gonna eat, they're gonna check a blood sugar. They're gonna think about how many grams of carbs they're consuming. They're gonna put that information into their pumps. It's going to suggest the bolus. Then they push the button to get the delivery of that insulin bolus, rather than doing all those multiple injections. Any questions? I also do advanced pumping classes because there are different ways that one could bolus. One could bolus on their pump, bing bam boom, it goes in, just like an insulin injection. Once you push that injection in, you can't take it out like, oh no, that's not the right amount of carbs. It's in, right? We can bolus, let's pretend we're going to a party and somebody with type 1 diabetes is on an insulin pump and we're going to a party and we're gonna eat those carbohydrates over 1 hour. Okay? So we can evenly distribute that bolus over X amount of time. And for the foods that are high in fat, let's say pizza, because pizza has all that cheese, so it is considered high in fat, we can bolus as a combination bolus, where the majority of that insulin is given as a normal bolus, and the rest extended out over time. So when I have advanced pump class, and I have a bunch of families coming, and the kids are on different pumps, I have pizza. So this way, they get an opportunity to bolus in a different way, and learn those different features on their pump. In terms of basal rates, you can do a temporary basal rate. Let's say that individual is on the Omnipod, and there's no way to disconnect, and they're going swimming. And swimming usually lowers their blood sugar. Well, then they can say, I'm gonna put a temporary basal rate on, so that I don't run the risk of having low blood sugar. Okay? But this is a disadvantage if somebody doesn't want to wear this apparatus on them. Okay? But the advantage is you can have different amounts of basal insulin throughout the 24-hour clock. Plus, there's different ways that you could bolus. Plus, there's those things, the features of doing a temp basal. If an individual's on Lantus 11-mere and they're gonna all of a sudden start exercising, but they gave their insulin at 9 o'clock at night, and now it's 3 o'clock in the afternoon, they've got to be careful. They're not going to run the risk of having a low blood sugar. So they may need to eat a snack so that they don't have a low blood sugar. But if they're exercising to try to lose weight, now they got to eat to prevent a low blood sugar. We've got to be careful about that. Then we want to talk to the doctor, say, hey, maybe we can talk about lowering my insulin so that I can start exercising and not have to eat for a low blood sugar. Okay?
When you swim in the site that you use for the insulin, do you have to put extra tape or something to make
Good
sure?
question. So the question was, do you have to put any extra tape when it goes swimming? No, the answer is no, you do not need to do that. But you want to make sure that you position, especially for this pump with tubing, you position that it's facing down Otherwise, you don't want sand getting in there, because when the snap, it's just a snap click. But if you have it up, that you have to do it this way, and you have sand stuck in there, it's not going to be able to go in. They do have a little cap there that you can close it up. Yes.
And no infections usually.
No infections.
Good.
You can get an infection at your site if you're not doing good hygiene, you're not changing it enough, all right? And if that ever happens, they need to go on antibiotics and let us know. High blood sugar. The causes could be not enough insulin, not enough medication. The insulin that you're using, you've been using for too long. There are manufacturers, they come with manufacturer's instructions, okay? It could be that you ate too many carbohydrates, you miscalculated your carbs. When we go out to eat dinner, does your plate ever come with a cute little sign that says how many carbohydrates are in that?
No.
No. Did you ever buy a pizza pie? And was every slice in that pizza pie cut evenly? Did that pizza pie come with a cute little sign of how many grams of carbohydrates are in there? No. So carb counting is very, very difficult.
How many are you supposed to have, an adult person? per day?
45 to 60 for your meals. 45 to 60. And it also depends on your weight and what the weight goals are. You know, if you need to lose weight, do you need to gain weight, do you need to stay the same? But that's about a ballpark figure. So we've got to make sure that the insulin has a non-expiry, you're not using it more than a month. It's at a controlled room temperature. Insulin that needs to be stored, it's got to be stored in the refrigerator. Okay, if we're using the pens, it says 28 days for the pens. The bottle opened, 28 days. Unless it's Levemir, that's 42 days. Signs and symptoms of high blood sugar are also the signs and symptoms of initial diagnosis of diabetes. Okay, drinking a lot, frequent urination, feeling tired, feeling hungry, changes in the vision, maybe you're having a weight loss. So when the blood sugar is greater than 250, for 2 readings in a row for somebody who's not on an insulin pump, we want them to check for urine ketones. And any moderate or large ketones, we want them to call us on the emergency line. What are ketones? Ketones are waste products that develop when there's not enough insulin. It's when the body is burning the fat as the main source of energy. And this is definitely not a good thing in a child or adolescent. If somebody's on an insulin pump, we want them to be checking for blood ketones, because that's a lot more accurate. And in a pump, we only have that rapid-acting insulin that's only lasting 3 to 5 hours. After that, they're at a risk for developing ketones. Sick days, we want them to check blood sugars more frequently. If they're ever vomiting, we want them to be checking for ketones. Yes, there could be a stomach virus going around and everybody's vomiting in the house, but since we have an individual with diabetes, we do want them to be checking for ketones and let us know if it's moderate or large. We want individuals to be staying hydrated. Diabetic ketoacidosis is a very serious medical condition. It's usually an admission to the intensive care unit where the acid level is at a serious level in the bloodstream. And they need to be treated and monitored very, very closely with a lot of different intravenous drips and an insulin drip until they're at a safe level, not only for their acidosis as well as for their hydration. Okay. But signs and symptoms could be a stomach ache, and it could be a sweet, fruity odor to the breath. Any questions? High blood sugar, sick days, pumps, we're good? Low blood sugars, the onset could be sudden. Signs and symptoms can vary by individual, but the usual ones are shaky and sweaty. And it's defined by a blood sugar of less than 70 milligrams per deciliter. So individuals who are on insulin are at a risk for developing low blood sugar and should always be carrying with them something to treat a low blood sugar, because it does come on suddenly and it's a bad feeling. And having a low blood sugar can also affect the way that you're thinking, because our brains need glucose to function. Okay. So the treatment is what's called the rule of 15. You take 15 grams of rapid-acting carbohydrates, such as 4 glucose tablets, half a cup of juice, any kind of juice, 1 cup of milk. Milk has natural sugar in it, it's called lactose. And recheck in 15 minutes, make sure that blood sugar is above 70. If it's still less than 70, you're going to treat it again with the 15 grams of carbohydrates. Okay? Nighttime low blood sugars are serious because usually people are sleeping and very groggy. You're not sure if you hear that. Infants may be irritable, crying in a different way, inability to fall asleep. They may wake up moaning, hungry, or restless. They may wake up sweating or having nightmares. Wake up with a fast heartbeat, wake up with a headache. The idea is to check the blood sugar. Okay, and then treat that.
That's the low blood sugar?
Low blood sugars. So we always want to and if an individual keep having low blood sugars, then we want to make insulin adjustments. We don't want them going low, okay? We want to be able to also teach them how to prevent a low. So we talked about activity. Usually you need to have 15 grams of carbohydrates for every 45 minutes of activity, or lower your medications if you know how to do that, or speak to the physician. We may need to increase a bedtime snack and make sure the bedtime blood sugars are above 100 because we don't want them dropping overnight. People can have what's called delayed hypoglycemia. Hypo is low, glycemia is the sugar in the blood. So somebody could be doing an activity in the daytime and it doesn't affect their blood sugars until they're sleeping. On a pump, we could do 10 basals. And individuals who are on injections, we can either lower medications, the insulin, or we can give them a snack before they go to bed to prevent that low. And the snack should be a carbohydrate that also and a fat and a protein. Like we're talking about kids now, ice cream, yogurt, okay, those types of peanut butter and apple. Okay, so that has carbohydrates and has fat and protein. Okay, because we want to make sure the blood sugar is up, but we also want to make sure that it stays level throughout the nighttime. We want to talk to the child the first time the child has a low blood sugar to help them identify what their body is feeling when they had that low blood sugar. So this way they make sure that they get immediate help. Okay, especially when somebody is newly diagnosed so that we can address this. They need to know what's going on. So even when I do my classes and it's a 6-year-old, does the child have to come to the class? Absolutely, this is their body. Yes, they need to come. I want to talk to them. I want them to understand. I want them to be able to tell a parent, an adult, if they're in trouble with the blood sugar. You know, they're not feeling well, so that somebody can help them out. We talk about Medical Alert. I believe there's some information there about the resources for Medical Alert, so that you have a necklace, a bracelet that says you have diabetes. And this way, if something happens to that individual, the EMS people will be able to identify, okay, this individual has type 1 diabetes, they're passed out, could be from a low blood sugar, and then we can get some glucose into them. Okay, inform family member, friends, and teachers, and we should always be prepared to treat a low blood sugar. Severe low blood sugar. Blood sugar could become so severe that an individual can have a seizure, become unconscious and have a seizure from a low blood sugar. The emergency medication is called glucagon. It is by prescription. So this is if somebody's having a seizure or passed out, you never want to give that individual something to eat or drink. So glucagon is a hormone. It comes in a freeze-dried tablet and a syringe filled with liquid. We just flip this off. Now this is an emergency, right? You have a child who's having a seizure. You're gonna make an assumption that is from a severe low blood sugar. Flip that cap off. This needle is gonna be longer than an insulin syringe needle or a pen needle for the insulin. Stick that in, push the liquid in, twirl it till it becomes clear. This needle is longer than the amount of liquid that's in there, so you're only going to stick this in a little bit. Take everything out, push the air bubble up, and this injection can be given as a muscle, in the muscle, or it could be given subcutaneous. And the muscle would be in the arm right here, we got a muscle, in the thigh we got a muscle. This is an emergency situation. Get it in, straight in, push everything, as long as they're above 3 years old, okay? Then you want to put them on their side, because the side effect to glucagon could be nausea and vomiting. Okay? Once they wake up, it will take a few minutes, you give them something to eat and drink. And then if this was our patient, we want a phone call to know what was going on, what happened. Okay? So that's glucagon, it is by prescription. If you couldn't find your glucagon, you would use your glucose gel. So these are items that we prescribe to our families. Glucose gel, you would put it on your finger, right? Put it inside, get it in there, and rub it. Use the whole tube of the gel. If you can't get inside the individual's mouth, at least put it on the lips, so it will be absorbed through the mucous membranes. You want to give something that's going to get that blood sugar up. In the almost 40 years that I've been on insulin, I never became unconscious from a low blood sugar. I never needed to have glucagon. So it is rare to happen, but it does happen, and it could happen, okay? Let's talk about the emotional aspects of diabetes. The diagnosis could come as a shock and may be overwhelming. There's feelings of guilt, anger, anxiety, sadness, denial are common. What about if it's an individual who, a parent has type 1 diabetes and now their child has type 1 diabetes? Don't you think they feel even worse, right? They ask, is it going to go away? No, it's not going to go away. Certainly type 1 won't go away. If they had a diagnosis of type 2 diabetes and they lose the weight, they may be able to come off that insulin if we needed to start them on insulin initially. Adjustment to living with diabetes as a family. We've got tasks of blood glucose monitoring. Who's going to be in charge of doing these things? If you have a young child, is it going to be the adolescent child? Who's going to be making sure that this stuff is getting done? Who's in charge of going food shopping and reading the labels? And you spend a lot of time reading labels,
Yes.
measuring your foods, understanding the role of exercise. Our office does what's called TrialNet screenings. So TrialNet, Pathway to Prevention, is an international study where they're testing the autoantibodies of first-degree relatives for type 1 diabetes to see if they have autoantibodies which could be present before an individual develops type 1 diabetes. So I have type 1 diabetes. I have 2 kids. For 10 years, yearly, they were in this study until they were 18 before they turned 19. So every year, they got their blood drawn to see if they had autoantibodies for type 1 diabetes. Thank goodness for them, it was negative. I do have families where 5 out of the 5 autoantibodies are positive. I do have one family where 2 of the kids already have type 1 diabetes, and the 3rd kid, age 5, has 5 out of the 5 autoantibodies positive. Now there's research going on where they're doing oral insulin, trying to trigger the autoimmune system to see if maybe they can delay the onset of type 1 diabetes for individuals at this high risk. That little girl would be eligible, but the parents are not interested in putting her in this other research. They're going to wait and see what happens. In the meantime, we're going to keep her in TrialNet doing glucose tolerance testing through the research protocol every 6 months. So.
It's more common now, is it?
It's more it's on the rise, but both types of diabetes is also on the rise. Yes. So that's TrialNet. What does the future hold? I have a paper here I hand out about heading for the cure at Cohen Children's Medical Center, where I'm the nurse manager taking care of these pediatric and adolescent patients who have diabetes. We're doing a program called Heading for the Cure of type 1 diabetes, where I'm gonna have the CEO and president of the Diabetes Research Institute Foundation talking about the stem cell research that they're doing in Miami, Florida. I'm gonna have another individual talking about the research that he was in, where it was called the bionic pancreas, where they wore glucose sensors, insulin pumps, to try to get this algorithm so that it's automated, so that you don't have to worry about the carbs that you're consuming and how much insulin should I take for it. Should I do temp basals or not temp basals? Okay, so they're doing this kind of research. And the JDRF, Juvenile Diabetes Research Foundation, that president and CEO is also going to be at that program, talking about the research that they're doing for a closed loop system, trying to make it seamless that sensors are driving the pump. So that's where research is going. Also going to have a young soccer player, Michael Thornton, who was at the conference Children with Diabetes down in Orlando, Florida this past summer, talking about how he manages being a competitive soccer player, taking care of his diabetes.
Are the stem cells being funded now?
Well, it's research. It's all research, and they are always looking for funding. You know, so I volunteer with all of these organizations on their fundraising events.
Government.
Is it government? The government tries to give some to some of these organizations through TrialNet as well, National Institute of Health. These are some of the resources. Every year, the American Diabetes Association comes out with guidelines. It is in a PDF format. It's called Diabetes Care, Standards of Medical Care. So every year, you can look for this online as a PDF. This is a great resource, Calorie King. Okay, you can also upload Calorie King to your phone. The JDRF sends us, thank you, bags of hope, and in the bag of hope, they give us there's a teddy bear. His name is Rufus. Thank you so much. So Rufus has patches where insulin injections can go. So it's going to go on the arm. He's got a patch on his belly, you know, by his booty, which is really that hip area, right? And on his legs. So this is a teaching tool. So all the kids get to have a nice teddy bear when they get newly diagnosed. I've got a bunch of stuffed animals on the top of my, in my desk, you know. So that's a sweet thing. Children with Diabetes. This is the program that they do every year down in Orlando, Florida. The site is an excellent, excellent resource. And the JDRF I spoke about, where they also do fundraiser walks. The American Diabetes Association, there should be information there about the walk on June 25th at Jones Beach. Be careful what you read on the internet. Not everything is accurate, right? I am the Long Island Advocacy Chair with the American Diabetes Association. They sent me to Chicago several years ago to learn about Safe at School. So Safe at School is making sure that there's no discrimination going on while the kids are at school. Making sure that they go on school trip just like everybody else goes on school trip. If there's a pizza party at school, making sure they're included in that pizza party, even if they need to go back to the school nurse to get a bolus on their insulin pump. Okay? So that's the Safe at School programs. And when it comes to the adult world, making sure that the adults who are living with diabetes are not discriminated against. So American Diabetes Association and advocacy is very, very important. In our program, we do transitioning from age 18 into the adult world. We have an adult clinic within our healthcare system, and they're very, very used to taking care of young adults, so we can send them right over within Northwell Health. Okay, teen issues. Who here has had teenagers? Teenager years, they go, they're past 18 now, right? They're into their 20s and they still got teenage issues. We gotta talk about what are those risk factors. Drinking alcohol, having sex, driving, going away, recreational drugs, college life. We talk about all of that when we do transitions of care. This was the first insulin pump in the 1970s. I was not on that. And this here we have where they're working towards closed loop, where they're going to have that, the pump is being driven by the sensors. And this is me. My passion is belly dancing. This was taken several years ago at the Jacob Javits Center, the American Diabetes Association, Diabetes Expo it's called, at the Jacob Center. And I use this in a lot of my presentations because, diabetes doesn't define who we are. Actually, one of my other young ladies that I took care of today, I was asking her, what grade she's going into and how's her summer. And she says to me, "Why are you asking me all these other questions?" I said, "Are you only about diabetes? Aren't you a person first, right? What about everything else in your life? And how do you feel about yourself? And how you feel about yourself, isn't that going to affect the way that you take care of yourself? So I want to know, are you in a good place in your life? You happy with yourself? You're doing okay? And if you are, then you have better chance of taking better care of your health. If you're not, then we need to address that and see what are those obstacles to taking care of yourself. What can we do to motivate you to take better care of yourself? When we think about people like Will Cross, who climbed Mount Everest with type 1 diabetes, how did he do that without his insulin freezing and going so low and high? And he's up there for I don't know how long he's up and trying to climb that mountain. I don't know why he would ever want to, but he did, and it took several attempts before he actually was able to do it. I'm just a little belly dancer on Long Island, but when I'm in a show and we got a few costume changes and I've got a pump on and I don't want anybody to see my pump sites or anything, I gotta think about where am I gonna put my sites because I don't want it showing. And then I've gotta, check blood sugars during this 4-hour show because I can't stay disconnected for 4 hours. I need to reconnect and get a little bit of that insulin because I do have type 1 diabetes. So these are things that are going through my head that I need to address so that I'm in top performance with the blood sugar in order to be able to perform as a good belly dancer, right? So, thank you very much.
Oh, thank you very much.